If you distill the fundamental idea of healthcare down to its purest, most unadulterated form, the essence of it just seems so simple. When someone is sick, they should get the care that they need. And this should be true for all of us humans living right now, forever on the cutting edge of the future, riding around on this blue and green orb through the universe and living our shared history as a species. But there's a heartbreaking reality to healthcare, and cancer in particular. The messy and upsetting truth is that the number of people who can get the best care, if we can even agree on what that means, which we can't, is fractional. Untold numbers of people can't even get decent care, and millions of people get absolutely no care at all. So why is that? There are glaring, enormous problems plaguing medicine and medical systems around the world. How do we unwind them? How do we even understand them? And for all the individuals in the world with cancer who are struggling, how can we bring them within reach? Can we create actionable solutions that alter the course of their disease and of their lives? It's a lofty goal, but it's the one we're going to tackle right here. I'm Evan Young, and this is Within Reach from Avalere Health. It was the best of times, it was the worst of times. In a hole in the ground, there lived a hobbit. Call me Ishmael. It was a dark and stormy night. These opening lines, like the opening of any great story, are undeniably memorable. Setting the stage for what's to come, your ears perk up. You inch closer to the edge of your seat in anticipation. The wheels of imagination that churn in your mind's eye start to spin into gear. It's not a coincidence that we typically begin each episode of Within Reach with a story. The power of the patient experience, and keeping patients at the center of what we do and why we do it in healthcare is as undeniably important as those opening lines you just heard. But what do storytelling and also story listening have to do with oncology? Well, as you're going to hear in today's episode, in which I sit down with Fionnuala Cowley, Assistant Professor of Medicine, Icahn School of Medicine at Mount Sinai, Ariel Siegel, very soon to be instructor in medicine, Harvard Medical School, and TJ Cimfel, Chief Creative Officer, U.S. Marketing at Avalere Health, stories turn out to be right at the center of it all. So kick your feet up, settle back in your couch, grab something ice cold or piping hot to sip on, because you aren't going to believe what we talk about next on Within Reach. Finn, Ariel, and TJ, thank you all so much for coming onto the podcast. I'm excited because today I think we get to have a little bit of fun. So I want to start with something easy for everybody, and that's a request for you all to just quickly tell me a story. And the reason that that story is going to be easy is because it's going to be about how you met. So, Finn, I'm going to ask you first to tell me how you met Ariel.
So I met Ariel the first day of fellowship during orientation. That was my first time meeting her. She loves Irish people, so we clicked almost straight away when she found out I was Irish. Their first outing, which happened like the following week, was we were both talking about how the fact Beyonce was coming and we really wanted to see her. Ariel had seen her like numerous times before. I'd only seen her once. So we basically spent the week tracking tickets to see her because she was coming to New Jersey that weekend. And then like 2 hours before she was supposed to come, we paid ridiculous amounts of money to go to the Beyonce concert and dance up at the very top of the stadium where you could barely see her. So that's where our bonding began.
Am I allowed to ask how much those tickets were?
No, you can't.
Nope. Okay.
My husband might eventually listen to this, so no, we can't disclose.
Some secrets in the marital domain need to stay that way. Okay, so Ariel, how about you and TJ?
Yeah, so kind of a funny story and a little bit random of how TJ and I met. But my sister works in the film industry for a production company called Scott Free. And so they were filming a movie that TJ wrote the script for. It's a movie called Night Watching. Go see it when it comes out. And I got to go to set with my sister for a few days. And so I was sitting in Video Village and watching all the action happen on the screens. And so then I happened to be sitting right next to TJ. And so then we hit it off there. And from my time watching the film over and over again, some of the same scenes, my friend and I thought it was funny to remake some of these scenes on our own, on our iPhone. And so We sent it thinking it was only going to go to my sister, but somehow it made it all the way back to the writers, to the directors, to the actors. And so that was my little claim to fame with TJ.
It was very, very fun to see that. And I think I saw that before I learned that you were in medicine. And I was like, whoa, this is crazy. Yeah, it was great having you on set. And it was kind of a fun little confluence of interests. Meeting in LA was, Ariel and I, we hit it off. I loved the little movies that she made. And so when we were talking about who might be great to bring on this podcast, Evan, I was like, oh, I know somebody who might be interested. And then we had the benefit of Ariel and Finn. And did you say you're going to bring Beyonce on to this podcast
episode.
as well?
She's coming later.
All right. Excellent.
She's practicing in the background.
The surprise guest.
So, TJ, I won't put you on the spot. I certainly didn't ask you to think about this, but I can't remember when you and I met. We've known each other for 8-9 years, something like that. But I do think I remember the first time I saw you in action presenting something. And that was out in Chicago as a part of our day jobs. We frequently have to present and tell stories, which, by the way, is going to be about a connective tissue that we're all about to get into a little bit more here. And I remember thinking as you were doing this presentation, my goodness, that guy is a way better presenter and storyteller than I am.
That's incredibly nice to hear. I don't feel put on the spot because you didn't ask me a question, which is great. I do know that when we discussed who might be hosting Within Reach, you were the first person I thought of.
Well, thank you very much.
Of course. The Mutual Admiration Society is always open here.
Yeah, that's great. So this is a podcast about oncology. What the hell are we talking about? Screenwriting and movie making and storytelling and things like that. It's oral storytelling. Right now, popular culture, take a look around you, right? We're actually in the midst of a cinema release that captures arguably one of the most important stories known to Western civilization in the Odyssey. So I think what is interesting to me here is that the value and the power of storytelling, as strong as it is in the human condition, certainly has a really important place in the care of patients and the practice of medicine. I think stories give you that shared framework of how we hand down not just our experiences, but also how knowledge is transferred, how wisdom is transferred. So I think that's a really interesting place to start, especially Ariel and Finn, with you both at the beginning of your careers here. Can you tell us a little bit about how storytelling is factored into some of the knowledge that you've gained as you embark upon your careers, whether that was from peers, whether that was from patients, other doctors? Talk to us about what storytelling has meant to you so far.
The thing about oncology that makes storytelling even more relevant is that even though this might sound a little bit counterintuitive, we get to know our patients for a long time. Not all patients, but we're fortunate to get to know some patients for a really long time. Being able to share stories and hear stories from our patients alone helps us to take better care of them. And I think this is what drew me to oncology, and probably similar for Finn at some level. But I think the idea of getting to share your thoughts and ideas and feelings and values and so on with patients is something that's at least important to me, because that's what makes me feel connected to a patient. And it doesn't mean I have to share all of those same values or whatnot with the patient, but hearing theirs also allows me to get to know them better. And so that helps us figure out how to better care for the patients and their families, especially as we have more and more tools now, more and more therapies to offer people. And I think the same is true just as we're just finishing up our trainee period, which is a long period. But I would say that all of these stories from our mentors, and I can think of one mentor in specific that I've worked with for the last few years, where I can just see how he interacts with patients and how he tells stories about his life to make some of these treatments more understandable. I want to use those stories of his experience to help me in how I explain things to my patients.
Every new patient that comes to see me, I ask them 5 questions as part of my new visit. The first is, tell me before this happened, what did a perfect day look like? And that always gives me a good sense of who they are, what they value, what are the most important things. I then ask them who supports them, who's their village, who's going to support them through the time coming forward. I ask them, how do they like to hear information? Do you like information in a lot of detail, or do you like information in big pictures? I ask them, when they've gone through something really, really difficult in the past, how did they cope with that? And what skills have they built up to cope with difficult times that might come in the future? And then I ask them, is there anything else I need to know about you as a person to take best care of you? And I think from the offset, when a patient comes, from asking those 5 questions, I have a very good idea of what their story is from the beginning. And that's really, really helpful going forward when we talk about treatments. And again, in the future, when we have to make difficult choices, kind of knowing who they are is really, really helpful. On the other side, whenever a new patient comes to see me, I also tell them the story of what we know about their cancer so far. So I have this sheet that I did out. It's split in 2. On one side, it says, where is the cancer? And the second side of it is, what is the cancer? And I think it's really important, as best we can, even though we're dealing with very complex ideas, that we try and explain that to patients and make sure that when they leave the clinic, they have an idea and have the story of what's going on with their body and what the future is going to look like.
That's amazing. So did you develop that initial conversation framework on your own? Is that something that you picked up along the way?
Yeah, so I'm also a palliative care doctor. So I did a whole year in fellowship that's focused on communication and managing symptoms and all of the skills that are really important in palliative care. The data for specialty palliative care basically shows that if someone, and I'll stick with lung cancer, someone that has advanced lung cancer, if they go to see specialty palliative care within 4 weeks of being diagnosed, they actually live longer than if they don't. They found that people who see palliative care early develop coping skills that basically help them cope later on. So I had to think long and hard when I started working as an attending last month, how I'm going to incorporate my palliative care skills. And that was something I really wanted to focus on, was the coping aspect. And when we think of coping, we think of what skills you already have. We think of who's going to be supporting you. And then we think about what are the things in your life that bring you joy and bring you happiness that we can make sure we prioritize during this very difficult time. So thinking of that, I came up with those 5 questions as kind of a pulse check on those many things.
TJ, we should have said at the top, you're an expert in healthcare communications. Also, we heard about some of your interests and some of the work that you do outside at Hollywood, which is really interesting, right? I think you live at the crossroads of storytelling exactly the way we're talking about it right now. So what's your reaction? Because I think it's really cool and very interesting that both Ariel and Finn are grounding those conversations they're having with patients in the realm of story.
It feels like it comes very naturally to you both. And sometimes it's like, sociology. We have terms that we apply to stuff, but really we're doing it already naturally. And I think that's the thing. We as human beings tell stories naturally. When you're put into a situation where your job is to treat and care for a patient, traditionally, it hasn't always been centered around the patient. It's been centered around the disease. And how can you knock the disease out? How can you get the patient better? But I think what we just heard from Finn too is that grounding your reality as a patient within a broader context is not just going to help you in terms of your own care, but it's going to help your doctor provide better care. And that actually, it's a question that I wanted to ask Ariel and Finn. I'm really curious, this concept of narrative medicine. Were you ever trained in that? Or was storytelling something that was a little bit more organic to how you've developed early in your careers?
During my palliative care year, narrative medicine was a module you could do. I would say it might not have been the most popular module just because it's a little bit more woo-woo, I guess, than what us in medicine are used to. And I think all of us probably prefer the hardcore science in many respects. So going into a situation where you have to write a story and then present that story to people in the group, I think a lot of people were not such a fan of it. I think storytelling for me, obviously Irish heritage is very storytelling based. So my parents actually own a museum where my dad does stories. Basically, he tells stories, old Irish folklore, and then specifically on like this period of Irish history from 1916 to 1922. He does presentations on that every day. So when I was younger, I used to work there every day in that museum, also doing the tours and doing the stories and telling stories to tourists for many years. So it was something I had a good bit of practice before I came. But the thing is, we talked about it with patients. It's also really important, I think, in research and presenting research, because it's easy to go up on a stage and just like flick through all the clinical trial slides. It's much harder to go up and actually put that research into a story that people can understand, both patients and also other providers. So it's also, I think, a skill that's very important from that aspect of communication as well.
We often say in our business, data is dumb. We have to ascribe meaning to it, find the meaning, and communicate the meaning in clear ways. So I see that very much connecting to what you just said. Before I respond to the woo-woo part of it, I'm curious, Ariel, did narrative medicine as a construct or a concept, was that something that was at any point in your...
Yeah, I don't know that it was formally taught to us the way that it was taught to our palliative care colleagues. We had a day in our oncology fellowship that we spent with the palliative care group doing formal training. But lucky for us, we had Finn in our class also. So she was always someone that was good to bounce ideas with. So we constantly had access to palliative care aside from our normal methods of communication. With me, I don't think it's something that I can formally learn. I just think the way that I've grown up, and I don't have a cool museum or anything like that, but I do have Jewish parents and grandparents. And so there's a lot of storytelling in that, regard, just traditions from the family passed on and whatnot. But I also think that's just the nature of how I get to know people. And like Finn had mentioned before, that with her 5 questions that actually give a lot of information and also probably make patients feel at ease that you want to know about them. Not only is it important to get information about them, but understanding their background and their story helps us to figure out what treatment plans are best for them. And my disease focus is multiple myeloma. And similarly, maybe even more so than the field of thoracic oncology, there's just been a boom over the last several decades of available myeloma therapies. And with so many therapies available to us as providers and to the patients, knowing what will fit in with someone's lifestyle, with their family's lifestyle, with what their interests and hobbies are, is something that was going to be very helpful in figuring out what the next steps are, especially when there's so many options available to us. And so I think the former paternalistic medicine approaches are evolving because we have the opportunity to learn more about our patients and their interests and their needs so that we can kind of collaborate with them to figure out what their therapies are, rather than just deciding this is how we're going to treat your disease, rather than you as the whole person.
I want to get to the woo-woo of it also. I want to think about where we exist in a world where storytelling, story listening, I think as you're describing it too, is really important. But also, we have the data side. We have this mass of pure knowledge, guidance, just a world of things that you need to lean on to make the decisions for your patients that you do need to make. So when a patient is answering those questions, Finn, or down the line as you're treating that patient for however long you may be treating them, how much are you listening to the patient relay a story versus how much are you trying to listen and pay attention to the symptomatology, right? And to do that more kind of data-driven doctor side of your brain, be connected to their care.
I think the issue is that like you've a limited amount of time, right? So even when I'm asking those questions, you have to be careful because it needs to be done in a short period of time so that the other like 10 people in the waiting room aren't going to be an hour behind, because you could be there forever, asking more and going deeper on those various things. So that's always a balance that you have to strike between needing to get through what you need to get through in the clinic visit, but also trying to get to know someone as best you can. I think when you're going into a clinic visit, there are certain things that you need to know, like Ariel said, when you're trying to pick a treatment. So those things you're obviously going to give a bit more time. For example, how are they getting around every day? What's their, what we call it, performance status? But, are they up and about during the day? Do they have support? So if I'm going to say they need, chemo radiation 5 days a week for 6 weeks, is someone going to be able to bring them in for that? So there are certain things that you're tuning in more to. But I do, especially in the first visit, do want to know more again of the story of who the person is within the time frame that you have on the day, which I think is always the limitation.
It's nice for patients to have you remember things about them. I mean, it's also just nice to remember them. And so I think there's certain patients that I'll see them enough, or I have a certain connection with them that I'll remember that they're going on a scuba diving trip off of Hawaii, and that's something that's really important to them. I try to keep the things that are very important to the patients easily accessible to other providers, because oncology notes can get pretty bogged down just because you can be caring for someone for 15 years and they've gotten 20 lines of therapy, and that needs to go in the note because it's important to their disease, but it can make it hard for someone who isn't involved in their care chronically to know what is important to the patient or what's relevant in the acute setting to a patient. And so, especially as you go from one provider to the next, or if you go to the emergency room and you're seeing an ED provider, that it's important to have what you find relevant for the patient's life readily available for others to figure out and to see in a timely manner.
So do you have an awareness of the way that the patient is remembering each one of their visits to you or their touch points? Are you helping to keep them organized, or do you feel like they're showing up and they're fairly on top of whatever their treatments are, whatever the last time you spoke to them may be? And do you ever have to feel like, hey, they're probably more aware of the last time we talked than I am right now. I need to catch up on them real quick because I'm limited on time. How does that feel when you're in the middle of it?
I think it can definitely be overwhelming when you're in the middle of like a fully booked clinic day. And that's me speaking as being a fellow, as I haven't started my new attending job yet. But I think that's what the whole idea of pre-charting is like. I think that aside from knowing the data of what's going on with the disease and all the biomarkers and whatnot, I think it's nice when I pre-chart and I had included in my note that this person was going on their European vacation. And so I can remember that. There's different parts of the EMR where you can write stuff that only you can see, which I also think is helpful, that if I knew that a patient had some hesitance about something or they had a lot of questions and that I knew they were going to need to hear it again explained, or that their family might need to hear it again explained, then I can write a note to myself that doesn't have to go formally in the chart. That can allow me to address whatever needs the next time I see the patient, that it doesn't put the entire burden of me having to remember every single moment of every single conversation, because a lot of these conversations can be intense and you're having a lot of them, back to back in a single day. I think as you start to get to know the patients more over a longer period of time, you just start to more naturally remember the things that are important to them, the way that they think about, their health information and their treatment plans and the things they might struggle with versus what they're more comfortable with. And so I think it's something that generally, naturally progresses as you get to know the person that you're taking care of.
I think there's an interesting pivot point here because, Ariel, you just mentioned you're going to have a patient, especially in multiple myeloma, who's living for quite a while with the therapies that we've got these days, 10 years, 15 years and beyond, hopefully. However, Finn, both you and Ariel are at the beginnings of your careers, I think. Certainly, you've spent a lot of time getting educated and learning the ropes, but now you're embarking upon everything. So I think to kind of pivot from storytelling and think about as you come in to the world of oncology as a professional, as a doctor, you're about to be doing this for however many years into your old age. What do you think you're looking forward to? What do you think that you, being of a different generation than somebody 20 or 30 years older than you, practicing medicine for that amount of time, that you can both learn from them, but also now bring with you into the field?
I think what's been really cool, because I guess I'm a month in now, so what's been really cool is when you're kind of deciding how you're going to be with your patient, what your workflow is going to be, what's your vibe going to be with your patients. It's nice that you're able to pick the things you liked from pretty much every senior doctor you've worked with for the last number of years. You also are able to be like, well, I didn't like how that person did that, so that's not how I'm going to do it. And then you get to put it together into your own way of doing things, which has been really, really nice. And I kind of thought, I know me and Ariel have spoken about this in the last few weeks, just kind of thinking about that and like how you want to do things. So one thing I've been thinking a lot about is my new patient folders, what's information that I want to put in there that patients might have questions about, but might not want to ask about. So some kind of more taboo subjects, thinking about that. But the other side that's a little bit more challenging then, and I think it comes back to more kind of the work-life balance, is that your inclination, especially starting off, is you want to be everything to them. You want to be accessible all the time. You want to do all of this, but it's a little tricky to be that for when your panel starts expanding. So it's trying to figure out how is that sustainable, how you can be the doctor you want to be, but also making sure that there are certain boundaries so that you can sustain this over a career of, 30, 40 years. So I'm still trying to figure that out at the moment, but it's been very nice to, as I said, come up with the way to practice that is basically an accumulation of so many years of training and the benefit of working with so many different great people over the years.
Yeah. And I think similarly to Finn, that we've just been in training for so long and we've been exposed to so many different approaches to patient care, some of which we love, and then some of which we're like, we're never going to be like that with a patient. For me, as you guys probably can tell just from speaking to me today, I often choose a more laid back approach when I interact with people. Being sometimes informal or more casual or warm in that way, I think allows patients to feel comfortable enough to open up with me about whether they think it's a dumb question or whether they think it's a silly question or something embarrassing that might be a little bit taboo to talk about. I've been able to learn from some of these attendings that are really able to just like allow people to drop their guards pretty quickly, which I think is not something that everyone can do. I think is a skill that I've been able to see in a few different attendings that I've got to spend a lot of time with, both on the inpatient side, which is a very different atmosphere than the clinic side, because on the inpatient side, there tends to be something acutely going on, which is why they need to be in the hospital. And so it's really been interesting for me to learn that from some of the more experienced attendings that have built up the confidence that they can be relaxed with patients. And so that's been something that I strive to do with patients. And of course, again, reading the room is an important skill, I think, for anyone that has a job that involves interacting with a lot of different kinds of people. You don't ever want to just cloud out what the severity of a situation is by being bubbly or lighthearted about something. But I do think that there's a fine balance that I've seen some of my attendings that I really, really admire do. And that's something that I want to take with me as I start in the coming months as an attending with my own patient panel.
A lot of what I'm hearing there, Ariel, is really one of the age-old qualities that we all want from our doctors, which is bedside manner. But I think a lot of times when we think of bedside manner, we think about the experience for the patient. But what's really interesting to me is what you're saying is by being able to read the room and bring a little bit of light into what is often, I would expect, a somewhat dark situation, you're actually creating the comfort within which the patient may be more likely to share. And that comes back to giving you an expanded view of them as a person beyond a patient, which again is going to give you the information that you need to provide the best possible care to them.
You're describing learning from mentors, obviously, right? I think you're picking up the best of what you've learned. You're discarding the things that you'd rather not model or a direction that you'd rather not take. Do you believe that there's a shift in medicine that's coming? Even though you're picking up these things and modeling them and carrying them forward, you're also developing your own specific individual approaches. So as you come into the field, what changes do you think that you as individuals and this next generation or wave of oncologists is bringing to the field with them?
I would say, in Mount Sinai, we have a very diverse patient population. So you have people that come in who are very educated. You have people that come in who know very little about cancer or what the cancer treatment might look like. So there's a real range. But I think we're heading into a time where patients are the more educated than they've ever been, and they have more tools at their fingertips at every hour of the day to give them answers to questions that they have, and to be able to communicate the answers to those questions in a way that might actually be better than some of the doctors they're meeting every day, which is a tough thing to say, but that's just the reality. And I think that means that you really have to know your stuff, and everyone everyone has to kind of be very good at communicating, because otherwise, last week I have a patient who everything I write in my notes, the radiology reports, everything, he puts it all into Gemini when he goes home. So when he comes in, he'll be like, well, Gemini had said this. And I was like, I agree with Gemini. We're all on the same page. So I think that's one big thing, that we're going to have second opinions from AI basically on everything we do. I think the other part is that for the first time ever, patients have access to everything now, which they wouldn't have had a few years ago. So one thing which is interesting is, if you were diagnosed like 5 years ago, you probably would have been told on the phone by someone, you have cancer, we're going to set you up with an appointment, and you were turning up and you didn't know who you were coming to see. Now, you can see on my chart a few days before what the name of the doctor is. It happens to me pretty regularly that people have Googled me before they come in. So they know who I am, they know what I've done, they know what I've been posting on Twitter. And also they have access to all my notes all the time. And also, sometimes they have access to results before I even get a chance to look at them. So I think all of that creates many challenges. I think ultimately better for patients that they have access to everything that's being written, and they are able to, again, have access to things at 3 a.m, that they're able maybe to ask questions about stuff if they're worried, where they might not feel the need to call us. But I think with that needs to come more conversations about when those tools are appropriate, when they're not appropriate, when you should be talking to your doctor and not talking to Gemini. So there's a lot you need to be, I guess, more aware of now than previously.
I entirely agree with Finn. I think in addition to having more access to your own health records, like Finn had mentioned, that sometimes patients will get information before their medical team. And so sometimes you see it happen in real time, that a patient is sitting in your clinic and they get their lab results and they're like, oh, we just got notified. They just came back right now. And then you can look with the patient. But then there's other times that a patient might have a bone marrow biopsy to see if their myeloma is recurring or progressing, or if it's in remission, whatnot. And some of these things can take a week, 2 weeks to come back, some of these tests, and they might see it when they're at home on a Friday night at 8 p.m. That means that as the providers, we have to be able to understand that patients are now sitting with certain anxieties that they might not have had before. I don't think that means that they should not have access to the information. It's their own health. So of course they should have access to the information, but it's just another skill that I think we're going to have to learn more and more with time, because this is something that's still, even in our short careers thus far, something that wasn't the truth when we started medical school and now is the reality. And so it's definitely an interesting thing to see patients come in and say, I haven't been sleeping for the last 3 nights because I saw these results on Friday, and then had the whole weekend to sit and kind of simmer with that information. And so I think with time, it's just something that we're going to grow with the patients to figure out how to navigate that. Otherwise, on kind of a slightly different tone in terms of AI, I agree with everything that Finn had said in terms of access to information for patients. In some ways, it's very overwhelming as someone early on in their career, but it's also, I think, been helpful in research in many ways, that obviously we can't have AI entirely independently do our research. But I have spent a lot of time with AI trying to learn more about statistical analysis. And so again, I still work very, very closely with our biostatisticians, because ultimately that's the final word. But it's been nice to get to learn on my own time and not have to waste one of our biostatisticians' time to learn what kind of analysis is appropriate in this specific setting. And so I actually think it's been a helpful tool in my learning of certain aspects of research. And it doesn't take away the need to do your appropriate reading and analyzing data on your own. But that's probably the most that I've implemented it, is learning more about the nitty-gritty stats of things that I don't have a formal education on, but have learned throughout my education thus far in indirect ways. But that's been pretty helpful to me in my research aspects of my fellowship training and whatnot.
Is there an institutional push towards using these AI tools in your practice? Is it strongly encouraged? Is it mandated? Because we're talking a lot about the individual finding the best use of these tools to enable and empower them to do their jobs better. But are there extrinsic forces as well?
In my institution, I think they want us to have access. So there also is such a range, right? So I think the one I use most often for practice is Open Evidence, which is a huge platform that's really after taking off. huge, and it's also free. So it's not like the others where like you get access to a not great model and then you have to pay for whatever amount to get access to the higher model. So it's free. It's, with these models, it really depends on what they're trained on. So in the case of open evidence, it's trained on NCCN guidelines. It's trained on, the highest ranked journals. So it's very good in terms of what it spits out. So we have access to that. And then we also have access to Gemini, I think, in our institution, because I think, everyone recognizes that it's going to come to a point that if you're not using them, you're going to be behind, because the issue is it's very hard to keep up in terms of efficiency with others if you're not using them. And so I know your question about, do we think like older generations are using it as much? I think it's a little bit like the same as society in general. I think you have people that are like, no, I'm not getting involved with this kind of thing. And I think eventually they'll decide they have to, because they're not going to work as fast or be as efficient as other people. And then you have people that have adopted it since day one, and they're, we have like a co-fellow who uses Claude to basically send him updates every week on what guidelines have been updated for oncology. So he gets an email with all of the guideline updates every week. So he's gone that far into it that he has it doing like research on the weekends when he's not even on the computer. So I think there's a huge range, but I think for most people, it is going to have to be part of your practice, because otherwise you're going to get left behind.
Do you think AI is carrying with it any risks to your profession in the next 5 to 10 years? I mean, it's so hard to like 5 years. It could be 3 months, right? It could be tomorrow. Something major could change. I mean, I don't think certainly that previous generations of people in any field have had to think about being replaced the way we're thinking about AI replacing us right now. So what do you feel like some of those risks may be?
I think one thing with the AI is at the moment, you can't take anything at even open evidence, which I think is one of the best ones. What it writes there, I always will double check. If it cites a journal, I will go and I will read the journal and make sure that that's correct. But it is very good at doing like the very tedious things. So example, if something gets denied by an insurance company, instead of you sitting there and writing out this really annoying email on like why the drug should be approved or why the scan should be approved, having AI do that, there's not really a risk to it as long as you read it and you make sure everything is correct, but it saves you a lot of time. In terms of the risk of them, replacing us and that they're not going to need doctors, I think that's probably, for our profession anyway, I think it's probably not going to happen, because I think at the end of the day, you don't want someone with you on your worst days of your life that's like a robot or an AI. I think in general, you want a human there that's able to be there and support you and support your families. I think we're protected from that. But I think everything that comes out of AI needs to be double and triple checked. I wouldn't be taking anything as gospel.
I'm clapping because if only every doctor that I've ever seen in my life who's providing me care practice what I believe is a level of skepticism that great doctors have to apply to their jobs. And I think what you described is exactly that. It's, okay, this tool is phenomenal. It does things you couldn't possibly have dreamed of. But everything it's giving me, I need to practice some skepticism, go find out what the truth may be and use my own intellect and digging to figure out and balance what I'm reading against what AI has told me. So kudos.
To me, that's one of my concerns overall is cognitive surrender. It can be very tempting to cut corners. It's great the acceleration that AI can help us. And it certainly is. It's helping make you smarter. It's helping make you more intelligent. And I think that that's one of the real powers. And my concern is always that it's actually going to make lazy people less intelligent, because they're going to start to over rely on it. And so I think that ties into that skepticism that you're talking about, Evan. And, I have little concern that the healthcare profession is going to be beset by that degree of reliance on this tool. But I do think there are other areas in our lives and maybe perhaps our careers over on the advertising side of things where it's like, hey, we got to continue stretching those muscles.
I think something which is going to be interesting, though, the more that it's used, and it's something that's come up in reviews for journals. So I've had it come up a number of times now in the last few months where I've submitted something to a journal and what I've got back is like AI slop. And in that case, it was like a bad model. It was like they didn't even pay for the full version. They put it into like the free version of the model and it came back a whole load of slop. And recently I did the review for a paper. And then when it came back after the editor reviewed it, the reviewer too was also AI slop. But the thing is, when you're someone who uses it and you're clued in, you recognize it straight away. And I think nowadays you can see it everywhere. Like you can see it in people's tweets, you can see it in the news articles, because when you know how it writes, you're able to recognize it.
Yeah, if I may, it's because I see it all the time on LinkedIn. There's a degree of confidence in everyone's writing now that it just wasn't there. And also, it's not this, it's that.
Yeah.
That is the deadest giveaway there is that something's been written by AI.
Yeah, it's trying to figure out, I guess, how we can use it as a tool, but as you said, not get like cognitively lazy that, that's all that we're reading and consuming is going to be AI slop.
So TJ, that's actually the thing I was going to push back on a little bit, because I want to make sure that I'm understanding what you're saying. So when you said AI can make you more intelligent, you're not actually saying that. What you're saying is people believe that AI may make you more intelligent.
No, I believe that AI can make you more intelligent. It's just in how you use it, and like even in terms of research. And, I believe Ariel was giving some examples of how you're using it to generate findings that are going to allow you to understand things quicker. I do believe that AI can make people smarter. I don't necessarily believe that the human instinct is often going to be to help me work harder and smarter AI. I think it's going to be, because I think it's human nature oftentimes is, how can we find the shortcut? How can we race to the bottom in a way? How can I take a pill to fix this thing for me? And so I actually believe that there is incredible potential for AI to enable us to become the best versions of ourselves. But I don't know that I trust much of the human race to necessarily use it in that fashion.
Well, you mentioned something there too that's really important to the practice of medicine, and that's AI can make us smarter, can make us more knowledgeable, could give us a lot more wisdom, it could put data at our fingertips. But I think it's very unlikely to have a level of empathy that is required of patient care, and particularly in oncology. So I'm not sure I look forward to the day where it can actually do that too. I just don't believe it's ever really going to get there.
Yeah, and I'll jump on that because I think that brings us full circle to the conversation around storytelling, the conversation around empathy, the conversation around not storytelling, but story listening. When we think about storytelling, it's fundamentally human. Yes, AI is going to be able to consume untold amounts of data and churn out a representation of a story. But at the end of the day, two people facing each other in a room and talking to each other in the context of more than just symptoms, in the context of what is important to me, what matters to me, what is the meaning that we are both deriving from this interaction with each other. I do think that that's going to be incredibly difficult to replace. And, at the end of the day, storytelling is neuroscience too. There are MRI studies, tests that show the areas of the brain lighting up when story takes place. It's hormonal. It's oxytocin. It's your cuddle hormone is activated when somebody tells you a story. And that creates empathy and trust. And that's, again, what I'm hearing a ton from Finn and Ariel is the importance of developing a trusting relationship. This isn't toenail fungus we're talking about here. Although if I had toenail fungus, I'd want to trust my doctor could help. But it really is about creating that two-way interaction where both people are giving something in the interaction.
The actual interaction with another person, like what you were saying, is the fun part. But ultimately, when I'm talking to a patient about the Knicks winning, I'm not having that conversation with AI. I'm going to know it's not a real Knicks fan, right? And there's something that's so nice.
Sorry, I'm afraid you just put Evan off.
Oh, sorry. Well.
I saw his entire body just shrivel.
Yeah.
Are you in Chicago, Evan?
No, I'm not. But what the Knicks did to the Sixers, which is my team in the playoffs.
Yeah. What they'll continue to do to the Sixers, even though you have LeBron now.
Okay.
But like, that's like, I have one patient who's a very, very big Knicks fan. And when he's doing well, that's mostly what we're talking about is the Knicks beating the Sixers and how much fun it is every single time in the playoffs. But like, that's something that you're not going to get from AI. And they might pretend to be a Knicks fan and hate Joel Embiid, but we know that if they were talking to a 76ers fan, then it would be a different story. And so I think in terms of AI replacing us, there's certainly tasks that it might replace that we do or might do better than humans. But I think at the end of the day, when a patient's probably in their most vulnerable time of their lives, that's not something that you're going to necessarily get from a computer. And like a computer's not going to, give you a hug if the patient allows it, And so I think that's something that, especially for palliative care, that, in Finn's role.
I'm glad you mentioned palliative care because, Finn, I was about to pivot to that same thing too and talk to you about that. In those really hard end-of-life conversations and the care that's required, what is your take on AI, empathy? I mean, these things that we're discussing here, these are particularly relative to AI. It's a really challenging conversation because nobody knows even where it's going, what it truly could be capable of.
There's different, situations in palliative care. And obviously we see people very early on now during their cancer journey and where it's again more around like coping and symptoms. And then obviously you have the other end of the spectrum which it's hospice and patients are in the last, few hours or few days of life. I don't really think right now AI comes into that. I think what is a little bit tricky though, when we think about palliative care generally, is that right now we have a real palliative care shortage of specialist palliative care physicians and providers. So 80% of patients get their cancer care in the community. 40% of those practices have access to specialty palliative care. There's a real issue with hospice staff shortages. So, something which we talk about a lot is in that setting where, you can't get access for everyone that needs it. What are some of the methods that we can employ where more people will have access to, some sort of specialty palliative care? So if you're in a rural area in the middle of nowhere, there's no access to palliative care. Is it better to have access to an AI that is able to ask you probing questions and ask you what you're worried about and validate? It's really understandable that that's, you're feeling like that, or kind of exploring things maybe that you might not want to say to your family member. Is that better than having access to anything at all? I think that's still up for debate. And I think that's what everyone is trying to figure out. Because if everyone could access all of these services, I think the same for counseling, psychology care. Obviously, very often there's a lot of co-pays and there's an entrance cost to that a lot of people aren't able to meet. So again, is it better that you're talking to an AI about how you're feeling and there's something happening versus not talking to anyone at all? I think it's hard to know. And I think we're going to need a lot more research in that area.
Thinking about an AI tool as a place to seek out emotional, mental, empathetic support for my condition, I mean, that genuinely makes me queasy to think about.
Yeah.
It really does. It's just so hard to really picture that being grounded in an emotional or empathetic truth that humans need.
It's sad. I understand the queasiness, but I also, when you set it up as just a dichotomy, is it better than nothing, And
I think what's a little tricky, and especially I think for people who maybe don't do the profession we do, what's very unfortunate, it's a sad reality, and I'm sorry to bring a big downer, but unfortunately, there are a lot of people in today's day and age that don't have friends and family. When I talk about the 5 questions I ask, it's not uncommon that I ask, who are the people you have? And people will say that there is nobody. And then we as the cancer team become their support in that situation. I would say the same, when people near the end of life, people that I've cared for in hospice, who again don't have anyone there towards the end. So I think often when we think about these things, we're thinking about it in the point of view of like our own context where that isn't the case. And we have a lot of people, I think unfortunately for some people, that just isn't their reality.
So we've talked a lot about story, and I do want to bring it back to that because I think there's an interesting thought experiment. It's a little bit of a creative one. I think we've been kind of creative with our approach to this whole conversation. Ariel, I'm going to have you field this first. If there is a story that you want people to tell about this generation of oncologists, the generation that you're in coming into the field, What do you want the story of your generation of oncologists to be?
I think we're a generation now that has had more accessible information than any generation prior. That's even new for us, right? I mean, in college, we were studying from textbooks in addition to the internet. And now I don't know that I've bought a textbook in a little while. And so I think our generation of doctors, of just our generation in general, and millennials, not Gen Z, we're very adaptable in terms of how we utilize information and resources available to us. And like I had mentioned before, that took me a while to get Venmo, right? And then I just did it, and now I'll Venmo away for the rest of my life, probably. And so I think just the way we utilize the tools available to us. And I remember that Finn was using Claude well before I had heard of Claude, and now Claude is my buddy, and I use it. And I found ways that I think it's helpful to my education and my ability to perform that makes me more productive. And so I think our generation of younger doctors, I think, is going to be a generation of doctors that is very, malleable in how we approach problems. And I think that will also allow us to maybe step a little bit further away from more of the paternalistic approach to how we interact with people, because we have so many more tools available to us, and that it's not just one correct answer for patients. And we're fortunate that we have all this access to information and resources.
I would say, I guess, the same as Ariel. I would hope that people would say we were nimble and that we were able to adapt to the times. I hope that we're able to continue, though, to be able to kind of drown out the noise, because I think in healthcare right now there's more noise than there ever was, because I think with a lot of this new technology, with our patients have access to MyChart, with the fact that we've instant messaging and the ER system between other providers, email, the research stuff, there's a lot of noise. So I hope that we're able to just keep present for our patients, and we're there and drown out all of the other nonsense that's going on around us.
The first email and IM that I ever sent as a person was in 1993.
That was when I was born.
Me too.
Oh, I remember.
Wow.
Clear as a bell. We were on these old MS-DOS computers, right, at college, in the college library is the only way you could get access to a computer. And there was some version of an IM where you could send a message to the person on the next computer. And then I remember telling my friends, like, yeah, it's called email. And they're like, what does the E stand for? And I'm like, it stands for electronic,
I think I was on the same computers around the same time as you, Evan, moving a turtle, like forward 10 and then turning it 90 degrees and moving it forward 10. And then you repeated that twice. And you know what it made? A square.
Wow.
Yeah. That's technology for you.
Yeah. Ariel, Finn, TJ, thank you all so much. It's been a great conversation. I hope you've enjoyed it as well. I know I have, so thank you.
Thanks for having us.
Thanks so much.
Thank you.
Go next.
Thank you for joining me on Within Reach, a podcast hosted by me, Evan Young, and produced by Avalier Health with the help of Podcast Labs. For more Within Reach content, including in-depth reports about cutting-edge topics in oncology, patient stories, articles, and more, visit withinreach.avalierhealth.com. You'll also be able to meet our SenseMaker experts who have worked hard to bring Within Reach to life. To get in touch, email us at withinreach@avalierhealth.com or follow us on LinkedIn. And who is Avalier Health? Avalier Health is a global strategic partner for the healthcare industry, working across the breadth of the product lifecycle to ensure every patient is identified, treated, supported, and cared for equally. Our advisory, medical, and marketing teams come together powerfully and intentionally to forge unconventional connections, building a future where healthcare is not a barrier and no patient is left behind. If you'd like to support Within Reach, please leave a review on Apple Podcasts or wherever you get your podcasts. Your input helps us make the podcast even better, points us to topics that are relevant to you, and helps us reach new listeners. All you have to do is open up the podcast app on your phone, look for Within Reach, scroll down until you see it, write a review, and tell us what you think. Join me next time as we continue to uncover issues in oncology and work toward their solutions here on Within Reach from Avalier Health.